Ladies and gentlemen, welcome to another interesting episode of our MedSynapse podcast series. I'm your host, Dr. Nigar, and I'm thrilled to introduce our esteemed guest for today, Dr. Ibrahim Jelaidan, for our second podcast on our MedSynapse series. Dr. Ibrahim is a distinguished figure in the world of adult cardiology with a specialization in advanced heart failure, adult transplant, and echocardiography. Hailing as a consultant at the prestigious King Faisal Cardiac Center, King Abdulaziz Medical City, Dr. Jelaidan brings a wealth of experience to the table. Not only is he instrumental in patient care, but he also serves as the Echocardiography Fellowship Program Director and Chairman of the Advanced Heart Failure and Cardiac Transplant Management Committee. Join us as we delve into the intricate nuances of anemia in heart failure patients, guided by Dr. Jelaidan's expertise and insights. Welcome, Dr. Ibrahim.
Thank you, Dr. Nigar, for this nice introduction. And I'm very delightful to be with you again in this very great, informative podcast. And I hope that we can deliver very useful information for our colleague in cardiology, internal medicine, and all area family medicine, and all other specialties who care of heart failure patient.
Thank you so much for being here on our podcast, Dr. Ibrahim. It's an honor to have you on this very important topic of anemia in patients with heart failure. Without further delay, let's begin with our podcast. Dr. Ibrahim, to begin with, could you elaborate on the prevalence and significance of anemia in patients with heart failure, and how does it impact the prognosis and treatment outcomes?
So, as you know, Nijar, that iron is an essential element for all form of human life, mostly for its ability to accept and donate electrons, and that will regulate the energy inside a lot of the cells. And we're not going to discuss a lot of the function today, but we're going to focus on the iron function in the heart muscle. For a long time, we did not correlate iron deficiency or anemia with heart failure, and we did not focus on treating that disease. But after finding a lot of data that iron deficiency actually is linked with worst outcome in heart failure patient, so not only decrease their quality of life by increasing their symptoms. Heart failure patient usually develop dyspnea and difficulty breathing and fatigue. So that usually is worse with iron deficiency. And also iron deficiency make the cardiac remodeling worse as well for those heart failure patients. So that's why there have been a lot of research and emphasis on the importance of iron deficiency in heart failure patients, and how we can treat that and how we can diagnose it and treat it, and not only by the heart failure cardiologist, but also with the help of all other physicians that deal with heart failure patients. So about the prevalence, it is very common. There are different data coming from different studies, ranging anywhere from 40 to 60% actually. So it is very common in heart failure patient to have iron deficiency alone or iron deficiency combined with anemia. And we are going, when we reach the diagnosis part, explain more about the definition and how we can say that this patient is iron deficient and or anemic. So we're gonna delve into the numbers in the next question. And as I said, it is associated with worst outcome for heart failure patient, and not only by worsening their symptoms, but also it is associated with worse outcome in terms of worse hospitalization, worse mortality, because of the negative remodeling effect and a lot of the other effect that is usually affecting heart failure patient.
Thank you so much, Dr. Ibrahim, for your response on the essence on recognizing the prevalence of anemia in patients with heart failure, as it's very important to address it promptly in our management strategies. Now, moving on to our next question, what are the underlying mechanisms linking anemia and heart failure? And are there specific pathways or physiological processes that intersect and exacerbate both conditions?
Okay, excellent question, Dr. Nijar. So Iron deficiency can happen in heart failure patient by multiple pathways. One of the most common pathway is basically similar to the pathways of other chronic disease. Heart failure is a chronic disease like renal failure and other inflammatory disease that affect patients. And with this chronic inflammatory states that the patient can be in, that's usually affects the degree of iron absorption in the body and utilization. So that's one of the main mechanisms of iron deficiency. As well, people usually with heart failure, sometimes they can have, especially a severe form of heart failure with reduced ejection fraction, can have poor nutrition, either because decreased appetite or sometimes depression that's come with a diagnosis. So that's also can contribute. Also, they can have occult bleeding. For example, a lot of the heart failure patients are also patients who are taking antiplatelets or anticoagulation to help with coronary artery disease or other indication for anticoagulation. And that can lead to sometimes slow bleeding process that will cause iron deficiency anemia. So there is a lot of processes that I don't want to go a lot of details about, but those are the main mechanism of iron deficiency anemia. And regardless of the reason or the etiology, as we said, it is very common in heart failure patient, affecting almost half of the patient if we took the prevalence for multiple of the study, like approximately, and it's affecting them in a negative way. So we need to recognize iron deficiency anemia in heart failure patient, and we need to be able to diagnose it and manage it as well.
Now, when it comes to clinical practice, what are the challenges associated with diagnosing and managing anemia in heart failure patients? And are there any unique considerations or complexities clinicians should be aware of?
Okay, another excellent question. So there are barriers, of course, that preventing us from recognizing this kind of anemia in heart failure patient. For example, the lack of understanding of appropriate screening pattern. I don't think a lot of the cardiologists, internists, or primary care physician who are dealing with heart failure patients are aware sometimes of the appropriate screening mechanism or how to do iron studies and how they can interpret the result of the data. Also, sometimes the difficulty of giving IV iron infusion in some of the clinical setting can cause challenges. Cost of IV iron sometimes can be a challenge. Lack of experience of some of the healthcare provider regarding the management of and side effects of the medication and the counseling to the patient about the importance of the disease. Provider time constraint, as many other interventions that we usually do, and also the appropriate follow-up of biochemical and clinical response to the IV iron therapy. So there are a lot of barriers that can prevent us from identifying this disease. I believe just understanding the concept itself, hopefully by similar podcasts and about doing lectures and more teaching about this, and as we're gonna do in the next few questions about identifying how we can screen for this in terms of what are the lab tests we're gonna ask for and how to treat and what are the guidelines saying. I think that will cover a lot of the deficiencies that are happening in the real world. Actually, there is an interesting study. I just saw it. It's a Canadian study looking at the outpatient setting clinics in Ontario province, looking for patients who are screened for iron deficiency anemia in heart failure population, and they found that almost like 36 to 37% of patients are screened. So we can say that only about a third of the patients are screened, which is really not that great if we think about heart failure as a chronic disease, that we need to do everything we can to improve the patient's quality of life and survival and decrease hospitalization. So we need to utilize every weapon we have in terms of to improve the patient's life. And iron deficiency anemia and its treatment, one of those important aspects, of course.
Definitely, Dr. Ibrahim. Diagnosing and managing anemia in heart failure patients poses its significant challenges due to overlapping symptoms and potential treatment complexities. I believe this highlights the importance of multidisciplinary approach and individualized care to address the unique needs of each patient effectively. Now, let's go to practical part of this approach. How can we detect when we should screen the patients, and what lab work should clinicians look into, including interpreting the results?
Excellent. So this is a very good point and a good, we need to be practical. We need to start screening the patients. So basically, I will make it simple. So according to the European Cardiovascular Disease guideline and the American Heart Association guidelines, they all suggest routine screening for heart failure patient. So we need to routinely screen heart failure patient with reduced or mildly reduced ejection fraction. That's mean anybody with the ejection fraction less than 50%. When we see them in the clinic, we should send for lab work to detect iron deficiency anemia. So obviously, the first thing to do is a CBC to look for the hemoglobin level so we can detect anemia. Most of the trials, when they included patient with a hemoglobin less than 13 to 15. So most of the trials included those kind of patients. So if you have a patient with a hemoglobin more than 15, we don't have a clear evidence of the benefit of replacing or treating. So look for less than 15 of hemoglobin in patients. So that's the first thing we do. The second thing we need to send is ferritin level and the TSAT or iron saturation level. Basically, we can detect iron deficiency by looking at those two blood work. Because if your ferritin is low, which is the store part of the iron, then you have an absolute iron deficiency anemia, and we look for the number of 100. So if your patient ferritin less than 100, that's an indication to call the patient iron deficiency. And if it's associated also with anemia, so then it's an iron deficiency anemia. If it's only ferritin less than 100, then without an anemia, we call the patient iron deficient. If your ferritin is between 100 and 300, but your TSAT is less than 20%, that's also make your patient iron deficient, but we call it functional iron deficiency. So because their stores are usually okay, but they cannot utilize the iron in a good way. So to summarize, do a CBC, ferritin, and TSAT level in the patient of heart failure with a reduced ejection fraction or mildly reduced ejection fraction. So basically ejection fraction less than 50%. So if you see them in the clinic, if they come to the hospital with an admission, you should do those blood works. And then after treating the iron deficiency anemia, which we are going to elaborate on in the future, we need to continue following those patients. One of the studies showed that patients usually, in the first time they come to the clinic, they don't sometimes have iron deficiency anemia with the first time they are diagnosed with heart failure. But after, for example, 6 months or 1 year of following up, they will become iron deficient and they will have anemia. So it's not a one-time process, it's a continuous process. And it has to be in the back of our head when we see a heart failure patient. Obviously, it's more important in patients who are symptomatic because most of the studies showed that the evidence is best when patients have symptoms. So obviously, we need to ask also about the patient's symptoms, the degree of dyspnea, if they have dyspnea with exertion, and that's one of the trigger also to look for iron deficiency.
Thank you so much, Dr. Ibrahim, for giving us an overview on the screening and lab investigations that doctors should follow and look into. Now, moving on to our next question, Dr. Ibrahim, could you please discuss the current evidence-based strategies for addressing anemia in the context of heart failure management?
Okay, excellent. So now after we understood the importance of iron deficiency and iron deficiency anemia in heart failure patient, how it affects them negatively in their prognosis and how common is this problem happened, and we now know how to diagnose it. So after we diagnose it, we have to treat, obviously. So currently, I'm not going to go through different trials because maybe it can create some confusion, but I will try to simplify it as much as I can. So first of all, oral iron are not that great. So we don't treat iron deficiency anemia in heart failure patient with oral iron pills. We need to have a lot of high concentration to be able to replenish the iron deficiency in the body, and the oral iron cannot do that, especially in heart failure patients, also because they have problem with absorption. So oral iron does not have a role. The evidence come to us mainly from IV iron studies. So we had a lot of IV iron studies. I'm not going to go into a lot of the details. The common one that showed a lot of significant heart failure hospitalization benefit and improve symptoms are the IV iron carboxymaltose. So basically, it's one of the IV iron component or medication that we use. Every hospital will have it probably in a different brand name, but I will be sticking with the chemical component of it, which is actually the iron ferrous carboxymaltose. Also, the European guideline added another medication called the ferrous diazomaltose, but the most of the evidence come with the ferric carboxymaltose. So basically now, what we do is we treat patient with IV iron. So once we discover that the patient is iron deficient or iron deficiency anemia, and we identify the patient is symptomatic, because most of the studies showed that it's included patients who are in YHA2 and above, then we start the treatment. So basically, it's an IV iron injection. It comes with different concentration. I'm not going to go into the exact dose, because that you should work with your clinical pharmacist in the hospital, because they should, and every hospital will have a specific regimen. But usually what we do is we look at the patient weight, hemoglobin, and then we give a dose, and then we follow the next time in a week time with another dose. The range of the dose usually ranging from 500 to 1.5 gram, so 500 to 1500 gram of ferrous carboxymaltose. Usually, every single dose should not exceed 1,000 milligram, and we should space the doses in a week time. So the dose usually can be given as a bolus over 15 minutes, so it should not make a burden on the IV clinic or IV setup that you have in your institute, and the side effects are very rare and usually are not seen in the usual clinical practice. It can be diluted also with some normal saline, but that's why I'm telling usually you have to follow up with your current, with the pharmacist that you're working with in your institute, to have a small, for example, unit to give IV medication, and also to have a certain a protocol to give it. And protocol can be available with the pamphlet that come with the medication to give the doses. And the important thing also is, if we replace the patient with IV iron, we don't just forget about the patient. We need to keep following up the patient. So we come see the patient after another 6 months, for example, and look for the iron stores and anemia. And if it still persists, we still give another regimen of IV iron. And we keep continuing following the patient, and we keep replacing the iron if needed. The last thing that I want to mention is there is no actually role for erythropoietin or some other stimulating agent, because there is actually a randomized clinical trial that looked into that, and it showed that it did not improve heart failure patient and actually increased the rate of thromboembolic disease. That was confirmed by later meta-analysis. So we don't use that in anemic patient with heart failure. So our main form of treatment is IV iron. We have multiple formula. The most evidence come with the iron ferrous carboxymaltose, and you have to discuss with your clinical pharmacist the exact regimen that we can give to the patient the IV iron with.
Now, coming to our final question for the day, Dr. Ibrahim, how do guidelines and recommendations from professional societies guide the management of anemia in heart failure patients? And are there any emerging trends or research directions that may influence the future clinical practice in this area?
Okay. Very excellent. So obviously we all now use guidelines in managing our patients, especially when sometimes heart failure patients are being shared with a lot of specialties, internal medicine, cardiology, family physicians. So guideline, it's a very important tool to unify our approach to patients. So I will use two very common guidelines, the AHA 2022 American guideline for heart failure management. So basically they gave it a class 2A recommendation in patient with HFrEF, so patient with ejection fraction less than 40% and iron deficiency with or without anemia. Intravenous iron replacement is reasonable to improve functional status and quality of life. So, and also they give class 3, so harm, that we should not give erythropoietin stimulating agent in patient with heart failure and anemia. So that's in terms of the recommendation from the American Society of Cardiology and the AHA. In terms of the ESC guidelines, so the European guideline, the 2023 one, which is the latest guideline, it gave it a class 1A actually. So it's a higher class of evidence to give intravenous IV iron supplementation for patients with heart failure and reduced ejection fraction or mildly reduced ejection fraction. So basically any heart failure patient with an ejection fraction less than 50%. And if they have iron deficiency, as we defined it with the ferritin and with the TSAT, so ferritin less than 100 or ferritin between 100 and 300 with a TSAT less than 20%. We give IV iron to alleviate heart failure symptoms and improve quality of life. So it's mainly for symptoms improvement. And they give it a class 2A. So it's a little bit less in terms of the evidence to improve to reduce the risk of heart failure hospitalization, because the evidence in that aspect is a little bit less. There's actually a recent meta-analysis that looked at all the IV iron replacement trial and actually found some benefit in terms of improving cardiovascular mortality and cardiovascular death. So that's why it's crucial to screen your patient and treat your patient. And also about a future direction, there's been now some discussion and some studies looking for IV treatment also in patients with heart failure and preserved ejection fraction. We still need more data, and that if that happen, maybe we can update you in the future about it, and that probably will be reflected in the guideline, inshallah.
Dr. Ibrahim, your expertise and dedication to advancing our understanding of anemia in heart failure patients is very valuable. Your insights shed light on the complexities of managing these interconnected conditions, offering practical guidance for healthcare professionals in navigating through similar challenges in clinical practice. Thank you so much for being here with us today. We deeply appreciate your participation and look forward to future collaborations on our MedSynapse platform.
Thank you very much, Dr. Nigar, for having me again. And as we said, really important for heart failure patients, screen for anemia and iron deficiency, because we don't just treat heart failure, we treat the whole patient, and we hopefully can improve their quality of life and their survival, inshallah.
Definitely, Dr. Ibrahim. Thank you so much once again for sharing your knowledge with us on our MedSynapse podcast series, and looking forward to many more interesting topics together.
Pleasure is mine. Thank you.
Thank you. And to our audience, thank you so much for tuning in to MedSynapse podcast. We hope you found today's episode as informative and engaging, and stay tuned for more thought-provoking discussions on medical topics shaping our healthcare today. Until next time, take care and stay well. Goodbye.